Generally, as gynecologists, we don't use too much of monopolar because either we are scared of using it, or majority of our surgeries are done with harmonic, and they use bipolar sharer itself. But you should always know monopolar is an extremely good instrument and technique which has its own flaws, but if you know how to use it, there is nothing like it, especially for adhesiolysis and all. Where do we use monopolar current in gynec lab? Vault closure, vault colpotomy, then PCOD drilling. So, yeah, when you have adhesiolysis where there is not much of bubble loops or anything, then you can use monopolar for omental adhesiolysis. Okay, they are the commonest ones. Second thing is you will have lecture on electrosurgery, so you will know which energy to use when, which instrument you have to use. Okay, what are the advantages, disadvantages. So now we'll come to the most important topic. This topic is important for people who have not had too much of exposure, or people who have exposure but they will be just doing a technique which they would have seen and learnt, not by proper training or without too much of thinking. So here we will take you through how you should start the surgery, before surgery what all you will do, and then how you will complete the surgery. So this is one of the most important topics according to me in the next 15 days. If you are thorough with this topic, then probably 50% of learning in laparoscopy is there for you. Okay, then performing the surgical steps is different, but to do or create whatever is required or steps that are required to enter into the abdomen, that is what you should be strong in, so you will not have any complications at entry. See, generally laparoscopic surgeries tend to take longer time compared to open surgeries. As time advances and as your experience increases and as your approach to each and every case, the duration of surgery actually reduces as compared to open surgery. With more and more confidence and use of better equipments, you can do a hysterectomy in 15 to 20 minutes. Generally, time is not to be considered in any surgery. It is the outcome, better outcome, that is important. It's not just the time. Just because you are doing it in 15 minutes doesn't mean you are doing it the right way. But generally, over a period of time, that amount of time you take to do a laparoscopic surgery will almost be equivalent to open surgery, or even you will be able to do lap surgery in a much shorter time. So for that, your positioning in the OT is very, very important. For you to be ergonomically properly positioned, so that your body is relaxed all the time, so that your hand movements and everything is in a very smooth, without much of rigidity, and you will be able to move your hands comfortably. Because it is for long duration, you have to have energy and muscle should be relaxed, and you will be able to do hand movements the way you want for a long period of time. That is why when you are practicing on the pelvic trainer also, I was telling yesterday, don't flex your hands too much at the wrist joint, and don't try to put too much of energy in holding the tissues. Whatever is required only. So your left hand, you have to be more cautious or conscious. Basically, you have to be very conscious all the time. How much pressure am I putting? Suppose I am retracting the uterus with a tooth grasper in my left hand, and I am doing the surgery with my right hand. With my right hand, I am doing something. So your thought process or your brain is fully involved in coordinating your hand movements of your right hand. But without your consciousness, you have to have a proper hold of the tissue, how much you are holding, with what pressure you are holding, get a good grasp of the tissue, so that even the left hand, what is happening is under your control. Generally, we don't do too much of things with our non-dominant hand, be it the right or whatever. Non-dominant hand is the one which we generally avoid doing work. as I was telling you, when you're practicing on the pelvic trainer, whatever is happening in the OT should be simulated on a pelvic trainer. So ergonomically, the surgeon, organ of surgery, and the camera, monitor, all this should be in one line. So that is why I was telling, when you're practicing on the pelvic trainer, you have to stand in front of the monitor. It's not the camera person should be given preference, you go and stand and do like this. You are not doing good job when you are standing in an ergonomically irrational position. You should be always in the right position, then only you will be able to do the better job. So this will tell you, this you would have seen. So for any hysterectomy, low lithotomy position is given with just a slight stirrups in the position in such a way that only the legs are flexed and widened apart. Not too much of flexion is happening at this level. Your first assistant is your camera assistant who will stand next to you. Some people, what they do is, there is one assistant who stands on opposite side of the surgeon. With his left hand he will hold the camera and with the right hand he will assist. That happens in some hospitals. Here we don't do that because we use the camera 30-degree angle telescope in the right way. We want both hands to be used when you are using the camera. Whereas if you are using a 3D telescope or a 0-degree telescope, there is no point in rotating the light cable. So there your assistant can use his hand to put retract or whatever assistance can be done. But if you are using a 30-degree scope in the right way, then the camera person should actually manipulate the light cable to give the better vision. Then, is this picture correct or wrong? What is wrong in this? Uh-huh. No, no. No, no, this is correct. What is wrong in this? Support is? So, patient is in head low position. So, before the start of Varis needle and primary trocar, you are not supposed to give any tilt or head low or any change in position. Patient should be in supine position. So, the priority is always first, before you start the surgery, make sure that the patient is in supine position. See, sometimes in some centers they give spinal anesthesia. So once they give spinal anesthesia, they'll give a little head low. You should never start the surgery when the patient is not in supine position. Even if it takes a little time for them to come and give supine position, wait for it. Second thing is, see, you all are commonly seeing stirrups where the knee joint is supported. That's not a good support. Ideally, this is a good support. This is one of the best kind of stirrups you can get. This is a vacuum based stirrup. Here you have the handle. So you paint and drape the patient. The surgeon himself can actually tilt the patient's legs however he wants. Okay, so this is an extremely good one and an expensive one, this stirrup. Okay, next, patient should always be in supine position. 30-degree Trendelenburg should never be given before you put your primary trocar. Legs apart with access to the perineum. Patient buttock is just at the edge of the table. All these are correct. The right arm is always stretched apart, and all your lap patients, you have to instruct the staff nurse to put IV line, IV access to the right hand and avoid using the left hand. Unless until they have some complication in the right hand or AV fistula has been created for dialysis, you avoid it. Otherwise, second thing is, there should be a strapping at this level, at the level of the chest. Strapping is not done. Preferably for all our gynec procedures, strapping is preferred so that patient doesn't slide down and the position doesn't change and the pressure points are not created after the surgery. Okay, that is very, very important. Shoulder stirrups generally we don't require until the patient is extremely heavy. If the patient is very heavy, then you can use a shoulder support, or else A simple strapping at the level of the chest, at the level of the nipples, you should make sure that patient is strapped, so that, yeah, you get a velcro strapping band, so that should be used, so that there is no single point of pressure, it should be uniformly distributed. Okay, these are the things. Next is when it comes to creation of pneumoperitoneum. So the first step in the surgery is creation of pneumoperitoneum. So the what is the most commonest preferred point of access? Umbilicus. Why do you choose umbilicus? Yes, all the layers of the rectus sheath are fused. Then cosmetic. Then okay, yes. Then so ease of entering is also much better with at the umbilicus. Then rectus sheath closure after finishing the surgery is also much easy, and you can do a better job if you are in the umbilicus. Okay, then yes, you can access the pelvis also, you can access the upper abdomen also. Suppose patient is having lap chole along with hysterectomy, so one port at the umbilicus you can do hysterectomy, and with the same port you can do cholecystectomy also. Okay, but what is the drawback of umbilicus? Yesterday only I have told you. Its position is not a fixed one. In some people, the distance between the symphysis pubis and umbilicus is short. In some, it will be long. Again, compared to umbilicus to xiphisternum, and from that also may vary based on the shape of the abdomen. Okay. Next important thing is when you are putting your Veris needle at the umbilicus, what else will you do? Okay, yeah. One is you have made sure that the patient is in supine position. Second thing is you have made sure that asepsis is achieved thoroughly, because umbilicus is one of the most unhygienic parts of the human body. That has to be clean. Next. Yes. Before that, what do you do? Palpate the abdomen. For what? Okay. What pulsations? Okay. What will you find out when you palpate the abdomen? Else was surgeons ನೋಡಲ್ಲ ಅಂತೆ. Okay, that you will get better information with a bimanual examination than a per abdominal. See, abdominal aorta bifurcates just 2 centimeters or just above the level of umbilicus. In some people, if the bifurcation, in 10% of them, the bifurcation is a little at the level of umbilicus or just below. So your port may go inside the vessels, your Veris needle may injure the major blood vessels. So in those people, you should be extra cautious. That is the reason we palpate the abdomen. Second thing is you palpate the abdomen to know the tone of the abdominal wall. You don't need to apply pressure, same amount of pressure in all the patients. Patients who are had deliveries or whose abdominal wall is lax, in them the amount of pressure required is less. Athletes, thin patients, virgin abdomens, it will be a little more. Pressure required is more. Next thing is, if you are not able to access through the umbilicus, where else will you go? Palmer's point. What is Palmer's point? One person can tell.
A line drawn from the midclavicular line and 2 centimeters below the left coastal margin.
Subcostal margin 2 centimeters below it in the left midclavicular line. That point is either 2 finger or 3 centimeters is the same. So that is Palmer's point. What are the precautions you will take when you are planning to put your Veris needle at Palmer's point? Yeah, okay. So how will you, suppose Rail's tube is not put, what will you ask the anesthetist? Was there any difficult intubation? If there was difficult intubation, they would have ventilated the patient too much. So in that moment, air would also enter into the stomach and distend, the gaseous distension of the stomach will be there. So your varus needle or primary trocar can go directly inside the stomach. Then what else? Hepatomegaly, massive hepatomegaly also you can feel if it is. Then splenomegaly and the stomach. Okay, these three things you should keep in mind. Next, there are other unconventional points like ninth intercostal space, then transuterine. They are not commonly done. Okay, you get extra long varus needle where if you are not able to access the abdomen through the create pneumoperitoneum through abdomen because of multiple scars or whatever it is, then just pass a sound, find out the direction of the uterus. In the same direction you pass the varus needle itself, puncture the uterus deliberately and create pneumoperitoneum. These are not commonly done, but these are also ways by which. What is another point where you can create pneumoperitoneum? Okay, what is modified Palmer's point? Superior margin of the umbilicus. Instead of putting your varus needle here, you put it at the superior margin of the umbilicus at this point. Because we as gynecologists, if we put our primary trocar here or the varus needle here, and then either this port becomes useless or I cannot use it for any purpose, so one extra port, because I may not be able to reach my instruments till the pelvis. Okay, so instead of putting it here, we put it here so that I can use this port for the surgery as such. Then there is one more point. What is epigastric port? So here between the xiphisternum and the umbilicus in the midline, around this area, around 3 centimeters or 4 centimeters above the umbilicus. So midline, lot of people do that. It's called Lee Hong's point. Okay, generally we avoid, as we are all trained under surgeons, we try to avoid going in the midline in the portion just above this, because patients who have had surgeries may have adhesions here also, so we try to avoid it.
Supraumbilical port, is it the same, sir?
No. Superior margin of the umbilicus is different. Supraumbilical is this epigastric, Lee Hong's point. Introducing the varus needle, check for patency or spring action. See, these things will be shown in the OT, but you have to be very vigilant and you should have this one, like, okay, these are the things they do meticulously in all the cases. It may look trivial initially, but these are the ones which will help you to do the surgery comfortably. Because you have not flushed the varus needle, you have just introduced it. You will think, okay, sister has checked it, and you will put in the varus needle, but actually when you connect the gas, the pressure is high. You are not, though you know that varus is in the abdominal cavity, it's not going, so you will start doubting whether I have put it in the peritoneal cavity or not, because there is a blockade, because the instrument was not cleaned properly, there is a blood clot sitting there and it's organized there, gas is not flowing. So such instruments will create more problems or panic during the surgery. So check all of them before you start the surgery. Then one is ensure patient is supine. Then incision, again, what we generally do is wherever we want to put the trocar, that is where we give an incision and put the varus. Some situations what we do is we just give a stab incision, create pneumoperitoneum, and then once pneumoperitoneum is created, wherever we want to put the trocar, we give an incision and do. So that also can be done. And then how do you hold the varus needle? Varus needle is always held like a dart, not like this, like this. Dart, you play dart, isn't it? So the varus needle should always be perpendicular to your hand, and then there is serrated edges at the tip of topmost portion of the Veris needle. So that serrated edge should be held by your index and the ring finger, middle finger, and then thumb on the other side. Then your ring finger and your index finger will, little finger will help in guiding you. So based on the thickness of the abdominal wall, if the patient's abdominal wall is only 1 inch thick, so your little finger will be set at 1 inch from the tip of the Veris needle, so that overshooting of your Veris needle won't happen. You got it? So lot of people put Veris in a different technique. This technique we follow because there is control at every stage. There is no overshooting. Okay. Then make sure that the stopcock is kept open, and then you flush and aspirate. You flush saline and aspirate as soon as you introduce the Veris needle. One more thing is missed. What did I tell? What did I tell you? Like before you introduce, what all should you check for? One more point is missing in this. Yes, the stopcock of the Veris needle should be open. Why? Uh-huh.
It has to be transmitted out. The air will be sucked in.
Okay, so
So the valve, the opening of the valve prevents that extra resistance.
no. Why?
If you have entered,
See, when you introduce your Veris needle, your needle is entering into a negative pressure chamber, okay, which has vital structures like bowel loops. So your needle, as soon as it enters, to prevent injury to the bowel loop, you have the blunt tip coming out, but at the same time, because atmospheric pressure is high, a small puff of gas enters through the Veris needle into the peritoneal cavity. So that puff of gas will actually push the bowel loops also adjacent to it a little away. So that also reduces injury. Okay, that is why we keep the stopcock open before we introduce it. Not after we introduce, we open the stopcock and flush right from the beginning. Then saline drop test, that you would have seen. Okay, place a drop of saline on the hub of it and lift the abdominal wall, it gets sucked in. Okay, but these are not very important. The one which is very important is rule of 5. Hello, Purnima, hello. What is rule of 5? Initial insufflation, intra-abdominal pressure should be less than 5 millimeters of mercury, and flow rate should be more than 0.5. So what is the flow rate that we keep when you are putting a Veris needle? It is 1 liter. Why should we keep it at 1 liter? Only 1 liter, is it? Yeah. So Veris.
Absorption of air returning is
CO2 is absorbed in the blood with 1 liter per minute. So if by chance if we have entered the organ or anything, the carbon dioxide that is there, it will get easily dissolved in the.
What organ?
So if we hit the momentum or any like bowel injury.
You are halfway there but not fully there. See, suppose your Veris needle enters into a bowel loop, it doesn't matter at all. If your Veris needle enters into a blood vessel and you directly release gas into the vascular system at 1 liter per minute, because carbon dioxide is highly soluble in blood, still patient will not end up in gas embolism, because by the time that gas reaches heart or the right side of the heart, by then it is already dissolved. But if you are allowing 2 liters, 3 liters, 4 liters of gas to enter into the blood vessel, then definitely patient will have embolism. So because of its solubility, very high solubility, at 1 liter per minute the chance of embolism is less. That is why you keep it at 1 liter per minute. So all of you know there is a blunt tip at the edge, and then you have the bevel shaped needle. Check if the needle is sharp or not, and then you can make sure that Veris will go in properly. Next, suppose you are not able to hold the abdominal wall. In those situations, you can take the help of your assistant, or you can even use a towel clip here to lift the abdominal wall. Don't use a Alice forceps. Never use an Alice forceps. Use a tenaculum or a towel clip, so that with that the grasp is good and it will not slip. Okay. Again, see the reason why we tell, see the angle between the varus needle and the abdominal wall is almost 60 degree. Even then it is not correct, because when Trendelenburg position is given, we feel that oh, bowel loops will go up, that is why injury will not happen to the bowel loops. It's not that, it is the vascular injury, because it's just very close to each other. So in this position, basically your varus needle should be pointed towards the sacral hollow. So the angle of insertion should be in the midline, facing towards the sacral hollow, and most importantly, the angle of insertion depends on the patient's abdominal wall. So thin built patients 45 degree, medium size built patients 60 degree. If the patient is obese, around 90 degrees. Okay, that is very, very important. Next, again, when it comes to primary trocar, it is again the same. Once you have created pneumoperitoneum, see there are people who create pneumoperitoneum, they keep initially insufflation pressure as 16, 18, and then they create a tense ball, and then they put the trocar. We don't follow any of those. That itself can compromise the cardiac status. We don't know in whom what's happening, though we have evaluated. Once they are under that kind of pressure, then only. And if your assistant forgets to reduce the intra-abdominal pressure after putting your primary trocar, then again patient will not have a good cardiac hemodynamic status during the surgery. So better is keep it at 12, maintain 12 throughout the surgery for almost all patients. In whom do you want to reduce the intra-abdominal pressure? Okay. Okay. Huh? Pregnant patients, you want to keep it at a lower pressure. What is the pressure that you want to keep at? Okay. So generally guidelines say it is safe to do laparoscopy anywhere between 8 to 14. We generally keep it at 10. All patients 12, 10 for pregnant women. Then when do you increase the pressure? In whom do you keep higher intra-abdominal pressures? No. Obese patients. Patients who are extremely obese, you will have to keep pressures of 14, like that. So that bariatric surgeries, when you are doing, pressure is kept at 14. Okay. Suppose for a short duration bowel loops are coming, your operative space is less, increase the pressure to 14, perform whatever vital procedure you are doing, and then you can reduce it to 12. Okay. Again, when it comes to primary trocar insertion, how do you hold the trocar? Has it been shown to you? So the trocar should hitch against the thenar eminence. Your index finger, middle finger will come on one side, and your ring finger and your little finger will go like this. So all the three will help in holding the trocar in a firm way, and your thumb will come on one side, index finger will come on the other side, and again the index finger, based on the abdominal wall thickness, you will keep how much ever. If it is this much of the thickness of the abdominal wall, you will keep your index finger at few millimeters little more than whatever is the thickness of the abdomen, so that your trocar goes in smoothly. Then how do you insert the trocar? Semi-rotatory. So semi-rotatory, we don't want sudden entry. You are not stabbing anybody. You want a controlled entry into the abdomen. So To have a controlled entry, a gentle, firm pressure is to be applied because the tip is sharp, it will help it. But that itself may not be sufficient enough for you to enter. So you keep doing semi-rotatory movement. It's a pyramidal tip. It's a pyramidal tip trocar which has sharp edges at the pyramid angles. So that will actually cut the muscles and slightly split. So your semi-rotatory will make way for the muscles to give way for your trocar to enter. If it's a conical tip, it's mainly suppression of the muscles that is happening, whereas with the pyramidal tip, a little portion of the fibers are cut and little bit is there by the pressure which will help you to enter. So you should know your trocar, if it is sharp, is it blunt, how is it, whether it's an optical trocar, is it a trocar with blade in the middle, what type of trocar it is. Based on that you will have to use your pressure. Okay. Next thing is, how do you insert? It is again inserted if the patient is extremely obese, vertical. If the patient is thin, as much as possible go at 45 degrees to 60 degrees. But not going too parallel to the abdominal wall, because if you go too parallel to the abdominal wall, your trocar will never reach the peritoneal cavity. It will all be within the muscle thickness of the thing only. So if you go the shortest distance required to reach the peritoneal cavity should happen. If you are putting your trocar like this, it will never reach. Though the abdominal wall is fixed thickness of it, your trocar will not be able to reach it. Even if we give a bariatric size trocar, it will not enter if you are oblique. So you should never go oblique. Second thing is, secondary trocar should go always perpendicular to the abdominal wall till you reach the peritoneum. Once you pierce the peritoneum, it has to be pointed towards the organ of surgery. Same trocar, when I am putting for a lap chole, I will put my, there's one trocar which when we are doing the laparoscopic cholecystectomy, you insert here, go perpendicular till you see the peritoneum. Once this layer of peritoneum is pierced and it just comes out, then if I am doing a laparoscopic cholecystectomy, I direct it towards that organ. If I am doing a hysterectomy, I direct it like this. But not from the beginning only I put like this. Right from the beginning, if I try to put like this, then I will be injuring blood vessels in the abdominal wall. So never go at an angle. Only till you reach the peritoneum you should go perpendicular, and then you have to point it towards that is for the secondary trocars. For the primary trocar you can never see because it's a blind entry. In those situations you have to go at the angle that I have said. If you are putting in the lateral positions, it's okay, go perpendicular to the abdominal wall. But if you are putting at the umbilicus, if the patient is obese, go as much as possible a little perpendicular to the abdominal wall. Then 60 degree for medium built, and a little for thin patients for safety purpose you can go up to 45 degree. Then where is the pressure coming for the primary trocar in your hand? This is just hitching against the thenar eminence, but where is the pressure or the force coming to introduce your primary trocar? It is the shoulder girdle muscle. See, your trocar will require more pressure or more force to pierce the abdominal wall, whereas varus needle will not require too much of pressure. So the force or the pressure required to introduce your varus needle will come from your wrist joint. So your even dart, see, it's how you release with your wrist. So varus needle is from the wrist joint, whereas the primary trocar, the pressure to introduce will come from your shoulder girdle muscles. Okay. Again, when you are giving an incision for the trocar, make sure that the incision is adequate. If your incision is not adequate, then entry of the trocar through the abdominal wall will be very difficult, and it actually stretches the skin through the trocar, and you will be feeling, oh, I am having a lot of resistance while putting, but that resistance is actually at the level of the skin, not at the level of the abdominal muscle wall. So you have to give sufficient incision. If you, around 1 millimeter more than the size of the trocar. If you give too much a bigger incision, then trocar will start sliding out and sliding in. That will happen. Next is gas leak will happen. So that should not happen. So see what is the type of the abdominal wall tone. Patients who have had deliveries and all, if it's a 5 millimeter, give only a 5 millimeter because it's already lax. In women who are tone is very good and the skin tone is also very high, in them you should give a millimeter more always. Okay, and then this is told. Sometimes in some patients the rectus sheath is extremely tough. You are putting good amount of pressure. In spite of putting good amount of pressure, your trocar is not entering. In those situations, what you can do is deliberately give a nick on the rectus sheath using a scalpel. So make sure that wherever you give the nick, the trocar should go in that nick only. Suppose I have given a nick here, the trocar should go here. So you make sure that your trocar is placed there only, or else you have given a nick here, but you are trying to introduce the varus needle trocar here, means it won't go again. And then when you are given a nick and you are introducing your trocar or the varus, even for the varus you can do the same. When you are introducing, you should not apply the same amount of pressure when you have the amount of pressure you had applied prior to giving a nick, because once you have given a incision on the rectus sheath, the amount of pressure required will be definitely very, very less. Okay. Again, see this. See the distance between the abdomen and the umbilicus and the major vessels. It is only this much. Whereas if your patient is in supine position, see the angle of insertion between the abdominal wall and the trocar. It is still 60 degree. It's not wrong. Whereas here also it's 60 degree. But where is it pointing towards? It's pointing toward the sacral hollow. Whereas this is pointing towards the major vessels. So that is why you should avoid that. This is what I was telling you yesterday. The distance between the umbilicus and the major vessels is actually 1/3 the distance between the whole length between distance between the umbilicus to the skin on the back. So 2/3 is here, whereas only 1/3. So it can be as less as 1 to 2 centimeters, and then bifurcation below the level of L4 is seen in 10% of patients. So this is the reason you should be very careful. Even a 10-degree tilt on one side can actually point towards the iliac vessels. So never put it in an angle. It should always be in the midline towards the sacral hollow. Then what is the technique till now we told you? It's a close technique. Close technique is blind technique. Some people do this on a routine basis called open technique. What is it called as? Hassan's technique or open technique. Here, instead of giving 1 centimeter incision for a 10 mm port, you give 2 centimeter incision. Separate the tissues between in the subcutaneous plane. The fat is separated till you reach the glistening white rectus sheath. Then catch hold of the rectus sheath, take 2 stay sutures and then cut in between the 2 stay sutures, and then you will get the rectus muscle. If you are exactly in the midline, you will not get the rectus muscle. If you are a little lateral on either sides, you will have the rectus muscle. Retract the rectus muscle, you will reach the preperitoneal fat or the preperitoneal fascia. Then separate the fascia and then you can see the glistening white tough structure, that is the peritoneum. That you will have to stab open and then you can introduce a blunt trocar. So that is Hassan's technique. See, basically people who follow open technique, they say, oh, my technique is best because there is no vascular injury, there are no complications. It's not true. Vascular injuries due to sudden entry into the abdomen is reduced, definitely, there's no doubt about it. But the incidence of bowel injuries, if there are adhesions, is not reduced, because again at the last step it is blunt. Even then, if you want to do, when you give a nick on the peritoneum, then again if the bowel loop is stuck there, then it will cause an injury. Okay, so incidence of bowel injuries will be reduced in open technique, but the incidence of vascular injuries are the same. Okay. Then the other thing is, nowadays with 5 trokers, 5 telescope, HD telescopes, we are doing almost all major procedures in 5 You don't need a 10 Suppose you are doing a open technique, then if the patient is obese, it's going to be extremely difficult to do an open technique. And you will have to give 2 centimeter sized incision, and again you will have to close all those layers. Chance of infection is more because you are handling too much. All those can be reduced. Your 5 trocar itself may be sufficient enough to do the whole procedure. Okay. But you should learn all the techniques. There are advantages of each technique. You should not say this technique is the best technique, whatever technique I follow. Whatever technique gives the best result in that case, you should do that technique. So you should know all the techniques of trocar entry. Secondary trokers, as I have told you, transilluminate the abdominal wall to identify the superficial epigastric vessels. From inside you see the inferior epigastric and find out a safe avascular zone and enter perpendicular to the abdominal wall. This is very, very, very important. If you insert perpendicular to the abdominal wall, the distance between the instrument or the trocar that is inside within the abdominal wall will be less or the least. Again, if you have the inferior epigastric artery, go lateral. So generally what we say is, at the junction between spino-umbilical line, anterior superior iliac spine to umbilicus, spino-umbilical line, lateral 2/3, lateral 1/3 to medial 2/3 junction. That is where it's a safe area. But that is on the right side. On the left side also, spino-umbilical line. In that line you can put it based wherever is the inferior epigastric artery, either lateral or medial to it. Okay. So generally for gynecologists, it's only the inferior internal iliac artery and its branches are of significance, but one artery which is the inferior epigastric artery, which is mainly from the external iliac artery, is of significance for laparoscopic procedures. Okay. These are all theoretical aspects. Okay. So the primary port, if you are doing only a diagnostic laparoscopy, suppose you are doing a hysterectomy, you want to do vaginally, but you still want to just have a look what's happening inside, see if there are any rectal adhesions or anything. So you put one trocar. So that situation you will use the umbilicus as the point of entry. So only for diagnostic you put one trocar, but even then you will require one more instrument to retract the bowel loop and manipulate and see what exactly. So generally what we do is, first trocar is put here at the umbilicus, second trocar is put in the spino-umbilical line wherever you want, that is the second trocar. And since here what we do is, we want all our energy sources to come from above. We don't want ipsilateral, because when your energy instrument is coming like this, you have the rectum, bowel loops, everything adjacent to each other. Whereas if your trocar is coming from the suprapubic area, it is only the uterus or the organ of interest that is there. There is no bowel loop. You would have seen, slowly you will start watching madam, when madam does, our energy source, that is the bipolar, monopolar, harmonic, all those will always come from the suprapubic port, because we use this midline port. It's neither an ipsilateral nor a contralateral. Okay, so one port is here. So this is the first port, second port, and the third port is in the suprapubic area, that is in the safety triangle. Okay, so what happens is, with this suprapubic port, I can reach the right uterine artery, I can reach the left uterine artery. Whereas if I put ipsilateral ports on one side, my left side hysterectomy is easy, but to coagulate the uterines on the right side, my instrument, if it comes from this side port, I may not be perpendicular to the vessel. So suppose you are tall and you are putting one more instrument, one more port on the other side, then you can put. If you are tall, it's okay. If you are not tall, or if you are not ready to go to the opposite side and do coagulation of the uterines, with the ipsilateral port, coagulation of the uterine vessels on that side is going to be a little challenge on the right side. Okay, so first, second, and then the third. The fourth port is put on the opposite side for the assistant. So this is called a diamond shape port placement. So generally what we do, if we are doing a lap chole, suppose gallbladder is here, so the surgeon will put one port just at the fundus of the gallbladder, so that his energy source will go directly to the organ of surgery. He doesn't want the energy source to come like this or from that side. It has to traverse directly from above to reach the organ of surgery. 1, 2 and 3 is sufficient, or 1 and 2 is sufficient. If you want to do ovarian drilling, ectopic without assistance, then 1, 2 and 3 is sufficient. Okay, if you want to do a simple cystectomy without much of this one, 1, 2 and 3 is sufficient. If you want to do a complex cystectomy, endometriotic cystectomy, dermoid cystectomies, then the same 1, 2, 3, 4 will be sufficient. If you want to do a myomectomy, 1, 2, 3, 4, same positions. Based on the size of the uterus, this diamond, instead of being it here, a little high up it goes. Again, if it's a hysterectomy, the same port. So we are trying to create things, we are trying to simplify things. Okay, this surgery I will put like this, that surgery I will not, because the organ of surgery is almost the same. Okay, in terms of gynec procedures I am talking to. Only thing is, because the size of the uterus is big, your ports are slightly high up, so that all your energy sources will come also without touching the organ of surgery.
This port placement, like C, it should be like 1 inch upper medial to the anterior superior reflex, right?
That is what I told yesterday. We never gave any fixed anatomical landmarks where you should put. I am giving you a zone. Based on a zone where there are no vasculatures, you can choose a point according to that case. According to that case. See, what happens with our technique is, based on the size and the pathology, we keep modifying. But the shape of the ports and the relationship between each port is the same. So the distance between two secondary trocars should be minimum of 4 finger breadth or 6 centimeters. Otherwise, sword fighting will happen. Both the instrument will go and hit each other, and you will not be getting a ergonomically good position. What is azimuth angle? Yes. I want you to read and tell me tomorrow. What is azimuth angle? There are 3 angles in laparoscopic procedure during port placement and instrument handling. You will have to find out all the 3 and tell me. Okay. See here, for simple hysterectomy, this is sufficient. If the uterus is big, the same thing goes up. But these two are not properly positioned. This also will go here and this also will go. So the same diamond shape will always be there. Diagnostic lab, this madam would have shown you, from one fundus and then round ligament insertion towards the uterus, and then to entry into the, that you should see. Then go between the ovarian ligament and the uterus on the right side to swipe the ovary, so that you can visualize the ovarian fossa, ureter, and then the entire length of the tube on the right side. If it is on the left side, this may not be possible all the time. In those situations, you have to go between the infundibulopelvic ligament and the bowel loop and then swipe up the ovary where you can see. So you can see the uterine artery pulsation and the ureter here. So this is the uterosacral ligament and this is the ureter. So ureter is always, here is the uterine artery. So ureter is always around 1 centimeter or 1.5 centimeter lateral to the uterosacral ligaments. So dissection lateral to the uterosacral ligaments should not be done unless you have done ureterolysis. So this will be covered in the pneumoperitoneum, all those things will be covered in the anesthesia class. Okay, then this is now we have finished the surgical aspect, how to create pneumoperitoneum, how to put your primary trocar, where to put your secondary trocar. But after you finish the surgery, again removal of the port, closure of the ports are also very important, because complications can happen even at that stage. So once your surgery is done, all the secondary trocars have to be removed under vision. That is one thing. After you have removed all the secondary trocars, open the stopcock or the primary trocar or the trocar through which your optics is coming, let out all the gas, and then once all the gas has come out of the abdomen completely, then under vision you take out the primary trocar. Anything I missed in removal of the trocars? That we achieve, that is not the thing. I am talking about releasing the pneumoperitoneum and removal of the trocars.
See the bowel loops.
Yes. So when you are removing the optical trocar after the entire pneumoperitoneum is released, you have to tent up the telescope and then under vision you take it out. Then one more thing. Huh? Yes. To ensure complete disufflation of abdomen, if the patient comes back to supine only, then only the gas will come out through the optical trocar completely, or else it will not come. So those patients will have shoulder tip pain if there is some amount of gas that is left behind. Why do they have shoulder tip pain? Yeah, why? How will it cause? How will it irritate the diaphragm? Why will it? How will it irritate the phrenic nerve? What will happen to the carbon dioxide that is there inside?
Gas will get displaced towards the diaphragm.
What will it get converted to? Carbonic acid. Carbonic acid is a nerve irritant. So that irritates the nerve and causes pain. Okay. Next, ports which are more than 5 mm should be closed at the level of fascia. This madam will show you when she is doing a port closure for 10 mm port, all those things. And then if ports are put, you put a 5 mm trocar, it has come out, then again you reintroduce 2-3 times in the surgery, it has come out and you have introduced adjacent to each other or in succession, then 5 mm will become 15 millimeters. In those situations also you have to close the sheath at the transfacial level, that is full fascia. You need not include the peritoneum, it's not mandatory, but rectus sheath has to be approximated and sutured. That is very, very important. If it requires enlarging an incision, it's still okay. Never compromise on not closing the rectus sheath properly, because that can lead to port site hernia. If port site hernia develops, it's an iatrogenic complication, and then that time once you release the hernial contents and then do a mesh repair has to be done. So to avoid all those things, iatrogenic things should be avoided as much as possible.
You have to go through it through the skin, or like
Not the skin.
the both side.
Yeah, what we do is transfascia is we go from inside of the incision, take the needle through the rectus sheath, catch hold of the suture material and come out, put a 10 centimeter length of the thread inside, and then through one side of the rectus sheath you go, catch hold one tip and bring it out, then again introduce at the other cut edge of it, go inside, catch hold of the thread of the other free end, bring it out and then tie it using the cobbler's needle, or what is its name called as? Carter-Thompson needle. Carter-Thompson needle, which you should. So how do you avoid hernias? Use minimum number of port, use the smallest diameter possible port, and then avoid violent and levering or torquing of ports. Again, avoid removal and then reinsertion multiple times. Then Z-shape fashion port introduction is not that easy, so not many people would follow it. Desufflate the abdomen completely when removing the ports, and then never remove the trocars when the gas is still there completely, because when you're removing it, the pressure inside the abdomen is more and the pressure outside is less, so it will pull whatever structures that are there adjacent to the trocar, it will bring it. If it's a bowel loop, it will go and get stuck in that port and it will cause intestinal obstruction. So that is not to be done. Second is that would lead to chimney effect. Never press the abdominal wall so that gas comes out. When you press that, the bowel loops, every momentum, everything can come, and if you are closing the ports by direct method, you may take a bite on the bowel loop also. These things have happened. Okay.